aesthetic side, this is a common clinical situation. Depending how you define the aesthetic zone, when you take it from the first to the first premolar, that's almost 40% of implants placed. And you see, very demanding. Because the problem is, if something goes wrong, it's a disaster most often, as we will see tomorrow. And we do most often today post-extraction implant placement. That means timing is a crucial aspect. Timing. That also means, I will show you tomorrow, see, when you have a tooth to be removed, you have to analyze a patient before you do the extraction, what you are planning to do for that site. Don't pull the tooth and then 3 months later you start to think about what to do in terms of tooth replacement. Very important. Okay. The patients are asking for what I said. They want to have aesthetic outcomes in the aesthetic zone. It should look nice. They don't like to have too much complication risk, and they want to have long-term stability. Long-term stability. It shouldn't only look nice for 2 or 3 years. It should look nice for the next 10 to 20 years. Now the reality is that when you do implant surgery and implant therapy in the aesthetic zone, there are cases where you have to renew the crown after 15, 20 years. That's an option. But you should not do every 10 years a new implant surgery. That is no option. So the implant should last. The crown might be removed and replaced because adjacent teeth start to darken. Sometimes patients continue to grow and then you get a little incisal step, so then you might have to adapt the prosthesis. And of course, as I said also this morning, we try to, let me go back once, sorry. We try to do these treatments with the least demanding protocol for the patient. Whenever possible, one surgery, one open flap, sometimes even no open flap procedure, but not very often. Okay. This one I have shown you this morning as well. You see, the clinicians are very important for the aesthetic outcome. Also the technicians, of course. So here we are not using any CAD/CAM technology with prefabricated crowns. We need a highly talented technician to come up with beautiful crowns, because that depends on the quality of the technician as well. So, for surgery, clinical skills, education, experience, we mentioned that before. Okay, the surgeon probably has the highest responsibility because when the surgeon is screwing up, as we said, then you have a disaster. So the surgeon will have to examine the patient to establish the risk profile. He will have to recommend a treatment plan from a surgical point of view. He or she will select the necessary biomaterials and of course perform the surgery. So the surgeon from the patient's point of view is the biggest risk factor for the patient. When a patient gets into the wrong hands, it can be a disaster. And that is the problem we see quite often. Okay, now when we talk about the preoperative analysis and when we talk about how to have a surgical recipe to get good implant aesthetics, I normally show this slide here. That's not a new slide. This slide is 25 years old. It's always the same. We have improved our knowledge in the first aspect, that is the understanding of the tissue biology. There we have made significant progress here. This is a big, better than 25 years ago. And this is important to know. You need to know how the tissue is healing. And then we do the aesthetic risk assessment. I mentioned that before. I show you the details now. Boom, 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 boom. Correct positioning, that will be discussed today, but also tomorrow. Then facial contour augmentation. will be discussed tomorrow in all details. Today we have seen a little glimpse to it. You see by the previous speaker, excellent outcomes. And the primary root closure in most cases. We close it up. Submerged healing, so that means no immediate restoration in these cases, in most cases. Okay, now let us start with the tissue biology. We need to understand that there is a concept, the biologic width. I'm sure you don't know the Carciulio paper from periodontal literature, that when you do crown lengthening procedures, that's based on the biologic width. If you need to have a crown on a tooth, you need certain distances, otherwise it's not going to work. It's the same with implants. When you look, a very nice outcome here, this is a 10-year follow-up case. And you see intact papillae, you see here, okay, I don't do it. Okay, and you see the mid-facial margin is correct, and you see the convexity. So it's coming out. It's not concave, it's convex. If it's concave, you get a shadow, it's very dark. It's not looking nice. Okay, so these are the three components of good pink aesthetics. Pink. The surgeon will influence the pink aesthetics, not the white aesthetics. That's the technician. Pink aesthetics. And you see the papers in the literature are going back to the mid-90s, early 2000s. Two preclinical studies, one from the Linde group, one from the ITI group. The Cochrane-Boozer collaboration, that's the second paper, and the Joseph Kahn, a clinical paper from Los Angeles. They show that the dimensions are very similar, very constant. When you look at this, then you see that actually mid-facially, when you measure vertically, that the distance is about 3 to 4 millimeters, approximately between a tooth and an implant. The papillae are stretching, and then you get nice music. Very good. 5 to 6 millimeters. This you need to know. When this adjacent tooth is extracted, then you're going to have inter-implant papilla, which is not a papilla anymore, it's inter-implant mucosa. And then you're going to lose the 5 to 6 millimeters, because it goes back to 3 to 4 millimeters. Good. Very important when you see cases like this, and these are patients with a lack of mucosa. This is not because you have not enough thickness of mucosa, it's because you have a lack of bone to support the mucosa. So when you try to treat patients like this, you have to ask yourself, there is a lack of bone, there's a bone defect. Is it possible to re-augment that bone? If so, if it's possible, then you can get it back. If it's not possible, then you have to think other terms, other solutions. It's mainly the vertical tissue deficiency. You have limitations. We will talk about that tomorrow then in full detail. Okay, so the bone plays a key role for the soft tissue aesthetics. There was once a saying by David Gardner in the mid-90s, you might have heard about it. He says, the tissue is the issue, but the bone sets the tone. Very smart sentence. If the bone is not there, forget about good-looking soft tissues. Okay, we go ahead. You need to understand hard and soft tissue alterations. Very important. And that means you see, legs of Dr. Shockley, I'm sorry for that, I did not see that, but I will explain to you later on the paper by Dr. Shockley. Here you see the thickness of the wall is very important. And this is also a very old slide, because I used it in the early 2000s when we start to understand why we have a problem. We said we have to differentiate thick wall, thin wall, no wall. And then we got more information out of that because of the cone beam CT. The cone beam showed us beautifully that if we have at an extraction site a thick wall or a thin wall phenotype, and that helps a lot. So when we analyze the patient who we are treating, this is another Megrana paper, ITI scholar from Croatia. We analyzed more than 100 patients to see what do we treat. And this study showed beautifully, you see that the majority of patients have either no wall or a thin wall. So the thick wall phenotype in the aesthetic zone is very limited, very low, in particular for central incisors. Central incisors, it's much more often, as you see here, it's much more often in the first premolar side. It's almost 30%. So first premolars have very often a thick wall phenotype, 28% exactly. Central incisors, 4%. Okay, this is not only in Bern, it's also the same in Wimba, as the Proudness in Bern. Januario paper was in Brazil. And the Vera paper is from the Lincoln group in Chapel Hill, North Carolina, United States. This is a common finding. I'm sure it's the same in Asia, where people always tell me in Asia people have even a little bit small volume of bone. I'm sure that you have the same thin wall phenotypes here. Then the biology of the bone defects, that's another one that you need to understand. We have a differentiation between different dimensions, the coronal apical dimension of a defect. We learned that this is not relevant. If it's only a 3 millimeter defect vertically or a 10 millimeter defect, doesn't play a role. Why? The bone does not grow from the apex to the crest. The bone grows from the side. Centripetal, as you say, like this. So that's no difference. What you need to know, that's much more important, that is the width of the defect. Can be a very crate-like defect. We call that a V-shaped defect. This is a paper by Joseph Kahn. V-shape can be U-shaped, or he says W-shaped, that's really wide. That is much more tricky than a V-shape. And the third dimension you need to know, that's the width of the crest. That means when you measure the crest at the proximal area of a single tooth, next door, and it's 7 millimeters or 6 millimeters here, and to put an implant in, put the implant in, then you have a two-wall defect. That's very important. You can have a deep two-wall defect or a very shallow two-wall defect. See, you see that here very beautifully. So here is the defect. So two walls, very important. So when you compare this now, a two-wall defect, you have a predictable bone regeneration, because these bony walls like this, they provide the bone formation. The bone grows out of the bone from both sides. When it's like this, the distance is much larger. If it's not two walls, then it's like this. Then of course it's much more demanding for the tissue to heal the bone. That's what you need to understand. So here you see, this is a Swiss Alps Valley defect, and this is a Grand Canyon type defect, as called that. This is a huge defect, like the Grand Canyon from the South Rim to the North Rim, 1.8 kilometers. Swiss Alps, when you go to the Matterhorn, in Zermatt, a huge, fantastic mountain. Then you go through a valley and you look up, that is a nice defect. So go for the Swiss Alps Valley defects if you can. Okay, what we also learned, you see, when you put an implant in, immediately or at 8 weeks. Immediate placement, early placement. We are dealing with a good defect configuration. So that's a nice defect, that's a nice defect. When you pull a tooth and let it heal and don't do socket grafting, you're going to see an atrophy. When you wait 6 months, it might be borderline. If you wait 3 years, then normally you cannot place an implant as easy. Because you get in a situation like here, here. So all of a sudden the exposed implant surface is outside the bone. There is no tooth defect anymore. So then the bone augmentation is much less predictable. So that's very important to understand this mechanism. Okay. Now we go into the detailed aesthetic risk assessment. It's mandatory, and this goes back to the treatment guide number 1. You can also read the treatment guide number 10. This is the most recent one. Number 10 is the last one published. Now comes number 11. I will go probably the next couple of months. And you see in this treatment guide, we have these parameters to be analyzed. This is aesthetic risk assessment. And you see that each parameter is either categorized by 2 or by 3 categories. So it is either low risk, high risk, or low, medium, high risk. And each one is explained why it is low risk, medium risk, high risk. And when in our department, you see my postdocs, they need to analyze every patient in aesthetics with this paper. If you want to have this paper, I will send it to you. Then they go through that checklist. So when I see an aesthetic case, I say, give me the checklist, and then takes me 3 minutes, I know what I'm having. Very easy. And then the postdoc learns very quickly, this is high risk, this is complex procedure, or it is low risk, much less problematic. And that's what you need to understand. So I show you now that, let me see, why don't I see here here we go. So medical status, and that's the first parameter. That of course, you can use that for all implantations. This is low risk would be a healthy, uneventful healing to be expected. And high risk would be a compromised healing. And we know there are a few parameters we have to be careful. And I give you here just some of the most important ones. We know from high risk factors for implant therapy are severe bone diseases, immunocompromised patients, or intravenous medications. Bisphosphonates, high dose. So, the high dose intravenous bisphosphonates, these are the tumor patients with bone metastases. There you should not treat patients with implants, because there you get this bone necrosis. Now today, some of the bisphosphonates are given low dose intravenously once a month. That's different. So this is in the flow in a moment. Then we have certain risk factors where we still treat patients. These are local radiotherapy, that's not in the aesthetic zone. These are mainly dangerous mandibles, so let's say where these mandibles have to be resected. Of course, uncontrolled diabetes, bleeding disorders, or blood coagulation medication, and of course also patients with mental or psychological disorders. You have to be careful. That's not a contraindication, but it's an increased risk for this kind of problems. Okay, smoking. Smoking, we talked about that. It's more non-smokers, light smokers, heavy smokers. So for me, a light smoker is less than 10 cigarettes. When I have a smoker that doesn't want to stop, I tell them, try to become a light smoker and go for 5-6 cigarettes a day. That means go for 2 packages a week. 40 cigarettes a week. Then you can make the calculation how many that is. So I tell them, like a ritual, you buy a package of cigarettes on Monday, another one on Thursday, Friday, and that's it. Then the patient comes down in the risk level. But a package a day or 2 packages, I have also made 3 packages. That's a big problem. We all know that. And this has been documented all and all. Many studies have shown that much higher complications are mainly due to infection. We discussed that before. Then we have 3 parameters we can discuss together. That's the smile line, you can call it the gingival display at full smile, a very strange word, smile line. Then the shape of the crowns and the gingival phenotype. I often put them together. So you see here, on the one side, this is rectangular teeth, high smile line. Triangular teeth, high smile line, rather thin tissue. Also thin tissue, triangular teeth, high smile line. This is 3 times high risk. When you have any problems in healing, you have a disaster very quickly. But you want to be very careful. You have to use conservative treatments, not to take the risk. Otherwise, you end in misery with these kind of cases. See, here you see 2 papers that often are cited. One is from John Coyce, and the other one is from a Belgian group from Deruk, Cousin, you see, 2009. It was the gingival biotype revisited. You can measure the gingival biotype or gingival phenotype, they call that. Often they take a metal probe, put them underneath into the sulcus, and if you see shining through the metal, through the gums, it's a thin phenotype. It's not so easy to make that distinction. Okay, then bone level at adjacent teeth. That's also an important one. Single tooth, where is the bone level at the adjacent natural teeth? So that can be the best estimated with the periapical regular. When it's fully developed, it's very good for you, because you know that bone is going to support your papilles. That's very important. When that bone is not there, and the bone is actually reduced in height, you get a shorter papilla. And then it's not your fault. It's the fault of the anatomy, actually, the patient's fault, that he came with less bone there. And of course, this is well documented by 2 papers, also early 2000. One is a Belgian group again, with Dennis Tarnow's influence, and the other one is an American group with Dr. Block. And what we have done, and you see here how it's measured, you can measure here the height, the distance from the bony crest to the contact point. And the magic number there is 5 millimeters. So when you measure there 5 millimeters, then you always have fully intact papilles. When you measure there is 6 millimeters, then the chances to get a shorter papilla, a black triangle, is not really that big, because then you just add a little bit of contact zone to the new crown. So it's not a contact point, it's a contact zone, and you don't have a black triangle at this implant crown. But when you have there 7, 8 millimeters, you cannot mimic that. Then you get black triangles. And important is that you analyze that before you do the treatment. So you identify the risk, you tell the patient, and you tell the patient, we're going to have here black triangles. Otherwise, he will blame you. So be very careful with that. So here you see an example. This patient came to me many years back, I think 2001 or so, just new gem, and she came to me referred. And I remember very well, because she came as an emergency. All of a sudden she had an acute symptoms of a tooth. And then she told me, I have this problem for months, but I was afraid to go to the dentist. Now I couldn't stay home. I had to go to the dentist, but Professor Musa, make sure I get beautiful aesthetics. And they said, you should have come earlier, you see. You destroyed all the bone around these tooth with this ongoing infection. If we are able to fix it, I have no clue. We'll see. We do our best, but you lost a lot of bone because of this infection. So, okay. Here you see the patient 5 years down the road. So we took the tooth off, let the infection be eliminated, then we did an early placement with contour augmentation, and so on. And then you see the contact zone, long contact zone, still a little bit black triangles, but actually it looks actually better than before. And when you look at the patient at 10.5 years, it has even slightly improved. So very stable, and you see that actually we got fairly nice, stable tissues for these implants. And when you look where we came from, I'm very happy with this treatment outcome. We were fighting hard to get it back to that level, but it's not perfect. Okay, then the infection at the implant site, you can have no infection, a chronic infection, acute infection. Is it the problem? No, it's actually not. Because you can change every patient in terms of infection to a non-infected site. Because the infection is caused by adjacent teeth, infection is caused by a root fracture, infection is caused by anything. So you eliminate the cause of infection, let it heal, and then you do the job. Then it's non-infected. So that's very important. That means when we have an infected site, we're not placing implants as immediate implants. Stay away from those. So that's very important. But actually that's not a very difficult one. If we have a perio patient, then we always first treat the periodontal disease. We never place an implant before that is done. So that's very important. Here you see a case where we have had a endoperio lesion with a huge bone lesion there. Here we have a post-trauma situation. You see here, you will see that patient tomorrow. Here with a fistula. Root resorption. So both teeth were pulled, nothing was done. 8 weeks later, implant surgery. Both without any infection. Okay. Then the restorative status have neighboring teeth. You can have virgin teeth, very naturally looking, and you can have restored teeth, not so nicely looking. It's actually not a risk factor, but if the patient wants to have a really good outcome, then you have to tell the patient to do that and to achieve that. We also have to work on the neighboring teeth. It's not done with the implant crown alone. Can be old composites, can be discolored teeth. We might even have to use there, you see, I don't know, new crowns or veneers, whatever, or you can also do, there are different options how you can do that. And you see here 2 examples on bottom, old composite fillings that had to be replaced, or then an implant that was placed in this area here, and next door we had to do a new crown. So here was the root with the root fracture. I will show you this patient tomorrow. Was treated in 2006, now more than 10 years ago. Okay, the next one is the width of the edentulous space. Is it a single tooth or is it multiple tooth gap? Single tooth, multiple. And that's a big difference. And we know, you see, when you have a single tooth situation, as I have shown to you, see, you have adjacent teeth, and the bone height at adjacent teeth will give you excellent support of the puppies. But when you have multiple missing teeth, there can be 2 missing teeth, 3 missing teeth, 4 missing teeth. These teeth, you're going to lose vertical bone in between the previous teeth because of bulbar bone resorption. So it flattens And then you don't get the papillis back. That's a big problem. And I will show you tomorrow that in this situation, we also use bone level implants as a routine, bone level, because you can optimize the volume of bone in between two implants. Also don't go there for tissue level implants when you have adjacent implants. When you have 3 missing teeth, then we go for tissue level implants. We have better results with tissue because in between the pontic area, we augment the bone vertically to get better soft tissue support. And then we don't use the bone level implants. I use the machine surface because of the tissue remodeling. Then the next one, again, 2 aspects together. Soft tissue anatomy, bone anatomy. Soft tissue defect, bone defect. And you see the red color is when there is a vertical bone deficiency and a soft tissue deficiency. This is very tricky. So that is a complex situation, and so on. And again, you see, you have seen that before, in particular when you have situations like this. You will see that patient tomorrow. This is the situation following the removal of 2 infected implants. Major tissue destruction. And we took the 2 implants off. We also took the 2 lateral teeth off because there was almost no periodontal tissue anymore, you see. And then we had 4 missing teeth, and we had 10 millimeter vertical tissue deficiency. I will show you how we deal with this kind of situations. We've been very predictable with these situations, I promise. 20 years of experience. Not many cases, about probably 20 to 30 patients well documented. Okay, for that we need, again, the combing. We analyze in detail, you see what we have. I showed you that before. You see I mentioned every case like this in a combing. I explained the patient where is the problem. That's the beauty of combing technology. The patient sits with you at the computer screen and you give them a much better explanation to the situation. They understand much better. Okay, now the last point is the point I mentioned before with William Chadwick. That's the facial bone wall phenotype. Is it a thin wall, a thick wall, or no wall? And you see, the green color is when you have a thick wall phenotype here. More than 1 millimeter of bone wall thickness at an extraction site, and thin wall is less than 1 millimeter. Thin wall phenotype. That's what I showed you before, and this is actually how we distinct. This is then tomorrow. I will show you tomorrow this slide again. You see the inclusion criteria to do what, when. When can we do immediate placement? When are we doing early placement? When do we need to go in for late placement? And you can see here, sorry, that was the wrong one. Here you see, for immediate placement, you need a thick wall phenotype, an intact facial wall. Then you can consider immediate placement. I will explain tomorrow exactly how that works. So, good. The last point is the patient aesthetic demand. That can be a major risk factor. So, not often, but sometimes you get patients, they have expectations you cannot fulfill, completely unrealistic. I have to say, most often, female patients in my age category having troubles to get older, and they come to you and show you the photography when they were 20. And then they tell me after 5-10 minutes, I would love to see again like this. Then I see they have a problem with their mental mind. So then I check the case and I see this cannot be achieved. Then I tell the patient, look, I cannot help you, I'm sorry. You have to look for another surgeon. Here is the door. Kick them out. Because be very careful, because they are a pain in the neck when you get when you start to treat those patients, they complain about everything and they blame on you, and they don't look like when they were 20. But it's not very often. 1 or 2 patients a year with these, let's say, wrong expectations, unrealistic expectations. That was one of my really worst cases. Similar. She came to me, she was treated by an implant specialist in a compliment. Absolutely crazy. 2 implants were placed in 2 central positions, and of course I don't blame her that she was not happy with it. And when you look at the implant platform, the implant shoulder is more apical than the apex of the laterals, particularly in area 11. And she of course complained heavily. And she showed me a picture like this and said, you see, I want to look like this again, you see. And then I said, look, I cannot help you. I think there is only one option here to really have a good look. We want to clear the deck, take all teeth off, and you get 4 implants and you get a very nice overdenture. Then that will look perfect. She didn't want to have it and said, okay, then that's it. I'm not going to spend any 5 minutes with you again, but this is never working what you want to have. She thought I can take these implants off, rebuild the tissue, and then somehow get back to when she was 20. So that was, I remember her, she's 20 years ago. She was the worst. That was even before the Twin Towers went down, also 9/11, because before that I always said it was a Twin Tower case. Looked like the Twin Towers in this month. Okay, now we go to the correct 3-dimensional position. That's the next one. And you see, in this book by Stewie Fromm, was published now twice. We had a chapter, and was one of the nicer chapters in that book, with 25 chapters. It's aesthetic complications due to implant malpositions. If you send me a request for the PDFs, I can add also this paper, the chapter. And so, we wrote it with Stephen Chen and myself. And so on. And this is actually, that's the paper I mentioned before. Where should the implant shoulder be located to have a good chance for aesthetic outcome? And we made a concept, we call it the comfort zone, the danger zone concept. It's very easy to understand. So we say the shoulder will dictate what you get. And the shoulder of the implant should be within the 3 comfort zones. There is a comfort zone orofacially, there is a comfort zone mesiodistally, and there is a comfort zone coronal apically. And an implant is too far coronal, so you see the shoulder, then it can never be aesthetic. If an implant is too far outside facially, then you see the metal, it's not aesthetic. And an implant can be too close to a natural tooth, then you lose the papilla, it's not aesthetic either. So this is very simple, and I will show you how that works. When you go for tissue level implants, we know that we get these saucer. Of course, in 2002, when we established this concept, we only had tissue level implants. And then we said we should have an implant always in a certain safety distance to a natural tooth. That should be at least 1 millimeter, if not 1.5 millimeter. So never place an implant too close to a natural tooth. Very important. So that's the saucer. Of course, with the bone level implant, you have no saucer, but you still should stick away from a natural teeth. Here you see an example. This is a patient that was treated in our department. And look here, there is no papilla. I give you the radiograph, you see why. The implant was placed, the wrong implant was placed. They wanted to place a narrow diameter implant, and then it was not stable, and then the surgical instructor told my postdoc, then we take a larger diameter to get the stability. They did not understand the clue. It was a big mistake. He got too close here, and that of course caused immediately, when the restoration was placed, the papilla disappeared within about 3 weeks. Then I saw the patient because this lady was complaining for good reasons. And so, you know how I treated her? I told her we can only help you when we pull the tooth. Then all the additional treatments I did free of charge to get rid of the problem. So then actually we did then here a socket grafting with a soft tissue augmentation, and finally she got an implant tooth supported 3-unit bridge. Very unusual treatment, and actually it worked out beautifully. And later on I did on that patient another 3 implant surgeries here and here. So she got out of it quite happy. And I was very happy that she did not complain anymore. Here you see then the comparison. That's why I said in single tooth situations I have a preference for platform switching implants, bone level implants, because you don't see then this bony saucer. It's very important in aesthetic science. Okay, and here you see how we do that. Also we keep a 1.5 millimeter distance. The green zone is the comfort zone. So when you have a patient, you measure the distance you have on the radiograph or clinically. So you measure at the crest area, not from contact point to contact point. And it should be at least 7 millimeters. For a center incisor, it's often 9 millimeters, so it's no problem. When it's a lateral incisor, it can be less, then you have to go for the smaller diameter. Bone level 3.3. Then you can do the treatment with 6 millimeters distance. Okay. Then corona apical. Where is the platform? The platform, you see that the comfort zone is not really large here. So 3 millimeters would be the distance from the future mucosal margin to the implant shoulder, and it's a bone level implant. That's the recommendation. It can be 3.5, it can also be 4 millimeters, but it should not be 6, because then it's really weak. So don't overdo it. Okay, now an implant can be in a malposition to corona or to apical. So here you see an implant to corona. The implant shoulder is at the CEJ of adjacent teeth. And of course, when this implant was placed in a private office, you see then it got exposed very quickly. And then he tried with 2 attempts to somehow fix it with alcohol. Of course it doesn't work. The implant is not in a correct position. The implant is too far outside and too far coronal. So I had to take it off. I will show you tomorrow how we treated that case 7 years ago. Here you see them at the opposite. Again, the twin tower case, implants too far apically. And often then you get these super long crowns. And of course, there's no harmony anymore. So it's not like this. It is like this, and then here goes up. And of course, when patients have a high smile, it looks fantastically bad. Patients are completely pissed. Okay. Why is it? You see, when you go for tissue level implants, then of course there is a saucer. And when you put implants too far apically, the saucer moves up. And the saucer has at least a millimeter in dimension, and then this resolves the bone. And then it moves up. Many of these cases were tissue level implants. And so on. Okay. So the recommendation is for tissue level implants about 2 millimeters of distance, and for bone level implants 3 millimeters, apical to the future mid-mucosal margin. When we have single tooth situations, I don't use surgical stents to do that. I do that because I have adjacent teeth. That's not difficult. But when we have multiple missing teeth, I use a surgical stent. And then the future margin of the crown is part of my surgical stent. I can only see where should be the future margin. And then I try to stay within the limits of these distances. This is what I showed you before, tissue versus bone level. And we discussed it already, so you see here the difference. And I also showed you this paper by Vivian Chapuis. And the Vivian Chapuis showed you that with tissue level implants you lose more bone compared to bone level implants. I don't want to discuss it anymore. You see, you're going to see tomorrow these cone beam studies where it shows how nice it is. You see, the beauty is here. Okay. See, that's a bone level implant, and you see the peak of the facial wall is coronal to the implant shoulder. That's only possible when you have a bone level implant. That's the beauty. So, and that's why I said yes, also in my previous presentation, you see, we augment always to the healing cap. We want to bring the bone further up than the implant shoulder, so the bone should grow here. Tomorrow I'm going to show you how to do that. Okay, what is the recommendation? Single tooth cases, no surgical stent, multiple missing teeth, surgical stent. That's how we do it. The last one is the orofacial direction. Where you put the implant orofacially. The simple recommendation is, you see, that we put the implants slightly palatal. Slightly palatal. That's not a big problem. You have to understand, when you have a tooth to be removed, the tooth has a dimension mesodistally and has a dimension orofacially, and it's not a round structure. It's often like oval, so it's wider than deep. So when you put our implant in, the implant has a round diameter. So we take a 4mm implant, then normally you end up inside the bone with 4mm diameter. That's a big advantage. So don't put implants outside. Don't use oversized implants. Don't use any 6 or 7mm implants in the aesthetic zone. Big problem, big mistake. Because that was recommended 20 years ago, didn't work at all because implants all got too far outside. Stick to 4mm implants or less. That's it. That works very nicely. So here you see an implant that was placed only slightly too far to the facial. And look here. See, this is the patient who got the recession. It took about 3 months to develop the recession. And you see how the implant was placed, too far facial. I had to remove that implant and retreat the patient. She was the daughter of a lawyer. So the first colleague who treated her paid the whole second treatment because the lawyer told him so. He was afraid to get into court battle and so on. Here you see another case where 2 implants were placed too far to the facial. And you see that they lost the tissue vertically and then they lost also the central papilla. That's not aesthetic either. Okay. Here now these are oversized implants. Oversized. 6-7mm implants. And these 2 in the middle. So they all have to be removed. I will show you tomorrow a single case that was treated now in the last 3 years with Professor Belzer. So what's the recommendation? This is a slide I showed you before. See, we want to have here an implant that has a two-wall defect. So slide it to the palate, very important. See, when you look here, the palatal wall has to be fully intact. And on the buccal is a defect. And what's also important tomorrow, I show you that when you go for bone level implants, the implant has to be the shoulder below the palatal wall, subcrestally. On the buccal we rebuild. That's very important. So now I show you 2 cases from the mid-90s. These are standard size. That means the implants were placed, the bone was intact. Since we had a flattening here, we did soft tissue grafting and then submerged healing. And then after 8 weeks of healing, we put the provisional crowning. You have to do a reopening procedure. And you see, this has not changed in 20 years that we are using normally 8 weeks of healing. And you see that when you open it up, then you see that the soft tissue is not really nicely maintained. You need a provisional, and then with the provisional do the soft tissue conditioning. Now this of course is a case with an old Opta abutment. This is not a Synopta abutment as we use them today, or some of the more modern kind of abutments. But the soft tissue conditioning is still the same. We use the crown to condition the soft tissues. For the patient, it's a very important phase. This is a prosthetic phase, of course. That means for the patient, the crown is then fixed. It's true retained. The dentist can remove it, the patient not. So then the patient has no hurry to move into final restoration. We often leave these provisional crowns for 6 months to get the tissue mature and so on. And when they have time, then we're going to convert this acrylic provisional into an all-ceramic crown. And most often, one piece and a ceramic as a silicone abutment and a silicone crown glued together. And that's what Professor Bellas was doing these days. But you see, that was the case in the late 90s. You see here, I think the patient will come in this year for 20 years. We'll see. I have not seen him for about 3 years now. He's in private office now, and he's doing very well. You see the soft tint conditioning, and then you see here the 1-year follow-up, end of 97, goes even more than 20 years. It's a tissue level implant, of course. And you see here the 13-year follow-up. It was done by Dr. Bruno Schmid, who is in private office now, and he maintains the patient. And this is the patient I showed you before, and you see now the treatment. You see, it was in 92, we did a little bit of bone augmentation in the apical fenestration defect, nothing else. I didn't want to use Gore-Tex because I would have required a second surgery to get rid of the Gore-Tex again, and so on. We had to do a little soft tissue grafting and reopening, and then the crown. And you see that the 10 years, you see a very beautiful crown for the implant, and that is here. Not very nice here, so here obviously she had an injury from the toothbrush that disappeared again. And then you see here at 21 years, the same patient, and she is now actually 25 years. I showed you the case this morning in the first lecture. She's doing fantastic. These implants are very stable, and the first aesthetic case. Okay, we summarize, and then we can conclude the first day. I wanted to show you when we go into aesthetic treatments, and this will be in the morning a big issue tomorrow. Then we have to understand that the primary goal of patients is to have a good smile. Of course, they also want to chew and they want to have a good speech, but the smiling is the #1 issue. These situations are demanding. It doesn't allow any mistakes, otherwise you get into troubles. The positioning of the implant is the #1 surgical that you have to keep in mind, and the re-establishment of a facial bone wall of sufficient thickness and height. Both. That will be shown tomorrow. Then we go for submerged healing, which is in normal case, no immediate restorations. So tomorrow we're going to talk about facial contour augmentation as part of our first lecture. Again, you see, for those who want to have a handout, you send us this email to this handout at CCPE. This, you cannot expect the handouts before Thursday. It will give me time to produce the PDF, send them back home, and then my collaborators will then give you the download link. They will add a couple of publications, also the original papers, like this Faden, and of course the 10-year study by Jacques and others. So I will give you some nice papers as well. Then for those who want to have still these